is Dr. Roshali from the medical team of USP, and a very warm welcome to all our speakers and our expert panel for yet another episode of CME India, brought to us by no other than Dr. M.K. Singh sir, in collaboration with Team USV. Today's topic for discussion will be urine ACR and the CV risk, what physicians must know, with our esteemed speaker, Dr. Rajiv Agarwala sir. And it's my privilege to welcome N.K. Singh sir today. He is a Director Diabetes Heart and Research Center, Dhanbad, Chairman RSSDI Jharkhand, and admin and founder of CME India WhatsApp group. It's an honor to have you here with us today, sir. I welcome you on behalf of Team USV, and over to you for the further proceedings.
Thank you. So today's webinar is very, very special that we are going to listen a very, very important topic by none other than the Dr. Rajiv Agrawal. I think I request now Dr. Akash Singh to introduce all our panelists today and also speaker. Dr. Akash.
It is my great pleasure to introduce our speakers and panelists today. The CME India webinar conducted every month is being conducted by Dr. N.K. Singh, who is the ever energetic brain and a person behind this group. He is a director of Diabetes and Heart Research Center, Dhanbad, former chairman, RSSJ, Jharkhand, executive member of National RSSJ, and he is ex-governing body member of National API, ex-chairman API. So he is thoroughly involved in the academic activities across India, day in and day out. The esteemed speaker for today, with whom I am very much impressed, is Dr. Rajiv Agrawal, and he is a director of Department of Cardiology at Jaswant Rai Specialty Hospital, Meerut. Doctorate in Cardiology, DM from G. Pant Hospital, New Delhi. Pfizer Medallion for all-round topper in MBBS. This department is the biggest referral base in India for Boston Cardiac Foundation, which implants free pacemakers for needy patients and holds Limca Book of Records for implanting maximum number of free pacemakers in India. He was also awarded as Paul Dudley White International Scholar Award, recognizing excellence in science from around the world by American Heart Association 2024. And as I know him, he is dedicated to teaching. He holds many lectures every week, and his passion is for delivering on the topics which are relevant in day-to-day practice and deliver practical messages for all the physicians to be used in the patients on day-to-day practice. He does not like to talk on fancy topics. He talks on very practical and the clinical pulse of the day-to-day practice which we encounter. So it will be a treat to hear him. Next.
Arufil, next. So I think now I have a great pleasure in welcoming Dr. Asutosh Chaturvedi. Today he is one of our moderator. So he is associate professor and consultant physician, Department of Medicine, Mahatma Gandhi Medical College and Hospital, Jaipur. He is also assistant editor at JAPI, governing body member API Rajasthan chapter, honorary secretary API Jaipur, executive members of RSSDI Rajasthan chapter, and CCDI joint secretary and faculty at many. You can see the national epicons and others, and awarded RSSDI USB Innovation Award also in Diabetes 2024. So welcome, Dr. Asutosh. Next, I have great pleasure again with my friend Dr. Sangram Biradar from Gulbarga. He is a great name in API, you know. He is MD, FICP, FACP, FRCP, and consultant physician and at the Gulbarga, and former professor of medicine at MR Medical College, Gulbarga, and a life member of API, CHI, so many. So next. Yeah, so now just that in few minutes, Dr. Harpreet Singh Tuteja will be joining as a moderator, director of Sardar Ranjit Singh Memorial Hospital and Research Center, Ambikapur, esteemed speaker at prestigious national and state conferences, and he is lifetime members of RSDI, API, and others, and published many papers also. So welcome, Dr. Harpreet Singh Tuteja. Next, you just heard about the Taka Singh. He is a part and parcel of also the CM India and senior consultant medicine diabetology from the Baroda, Gujarat. invited faculty of many national, regional, and state conferences. Rather, you can say in most of the conferences, you can see him and hear him. So welcome, Dr. Akash. And next, none other than our Dr. Vijay Patni. He is also our part of the course we are conducting with the CME India on the diabetes, and he is the current, he is the HOD Diabetes Wellness Clinic Kolkata, membership of all important associations. Many research he has contributed. Awards and achievements are too much. So welcome, Dr. Vijay Patni. With that, Dr. Singram Biradar sir, can you just give a opening remark on the topic so then we can start?
A very good evening to one and all. I thank Dr. N.K. Singh for giving me an opportunity and the USV team, as we are eagerly waiting to hear from Dr. Rajiv Agarwal, one of the prestigious speaker. We have heard him many times. The topic which he is going to speak is on urine ACR, what physicians must be we are aware. I think we can go ahead with the talk, Dr. Rajiv Agarwal. We can discuss the things later on.
Thank you, Mr. Chairpersons and all the colleagues on the board. It is immense pleasure to speak something in your presence which has lot of implications. Before I start, let me say this is one of the favorite photographs during Indo-Afghanistan war, and the reason why this photograph was the best photograph of the year was that somebody was so innovative in adverse situations. And they wrote, when all men think alike, no one thinks very much. So we have to have new thoughts, how we can make a difference in care of community. Majority of us are focused on EGFR, but I find a lot of ignorance among my cardiology colleagues, at least, related to urinary albumin creatinine ratio. As you know, albuminuria occurs when the kidney leak albumin protein into urine, and it is measured by urinary ACR, and it reflects both kidney and broader vascular health. I think that is the most important point, that the urinary ACR reflects broadly vascular health. This is a simple nomenclature. Less than 30, we say it is normal. Microalbuminuria between 30 to 300. Macroalbuminuria more than 300. If we broadly look, prevalence in older individuals, lower estimate is 15%, 20% people will show, older people more than 65 may show urinary ACR positive. Diabetics, as they advance in the natural history of diabetes, the number of patients showing urinary ACR increase from 30 to 40 if it is more than 10 years of type 2 diabetes. Up to 40% patient can have urinary ACR positivity if they are hypertensive, and 60% in chronic kidney disease. All of you must be aware that N-terminal proBNP is a poor marker of heart failure in obese people. Similarly, obesity is associated with increased creatinine excretion, and ACR underestimates albuminuria. Unfortunately, we don't have classification for obesity, urinary ACR, and one has to carry in mind that urinary ACR may be underestimated in obese people if the BMI is more than 30. Broadly speaking, the relative risk of CVD is 1.4 to 2.05 times with creatinine more than 1.4 to 1.5, just a borderline rise. If it is microalbuminuria, it is 1.5 to 3.5 more risk than EGFR. Annual mortality from CVD is 10 to 100 times greater with kidney disease. Many of us are aware of urinary ACR following SGLT2 inhibitors and GLP-1 receptor analog in HFrEF patient because it produced a lot of data that HFrEF, albuminuria, and these new molecules, how they interact. But really, we very little understand and appreciate that urinary albumin creatinine ratio is also a prognostic marker for atherosclerotic cardiovascular disease. Atherosclerotic cardiovascular disease. Heart failure component is well appreciated. So one can make out that if the proteinuria is more, the CV endpoints are worse. Look at the stroke and coronary. As the proteinuria increases, the risk of stroke and coronary event increases. My emphasis is to reinforce the concept of albuminuria as vasculopathy reflecting on atherosclerotic disease. Because many of us are well aware that this is an important thing in HFrEF patient, in chronic kidney disease. Then again, heart and kidney, CV composite endpoint, they are linearly related to increasing urinary ACR and poorer outcomes. Just emphasizing that urinary ACR is not a marker of kidney disease, but it is a marker of generalized vasculopathy, and it reflects on vascular bag. Urinary albumin creatinine ratio is an independent predictor of long-term mortality in atherosclerotic cardiovascular disease. And higher the tertile, higher is the mortality. 1, 2. So whether you look at the entire cohort for atherosclerotic cardiovascular disease or chronic coronary syndrome or stroke, there is a very strong correlation that vasculopathy is associated with linear relation of urinary ACR. What happens that if it is associated with type 2 diabetes mellitus? Again, showing the same thing that in diabetic patient, you have disproportionate event rate on vascular front in patient who have higher urinary ACR. Then again, cardiovascular mortality in coronary artery disease patient with or without type 2 diabetes mellitus. Again, you see CV mortality, all-cause mortality. Red is when it is more than 30. You can see overall CV mortality without DM, they are better off, but worse in diabetic patient. And this is all-cause mortality. So one has to understand that urinary albumin creatinine ratio is a marker of vasculopathy. And look what ranges we are talking. I told you up to 30 is normal. Here it is less than 10, 10 to 30 and more than 30. So even at a very, very low range of urinary ACR, which as a clinician you do not appreciate, the risk is exponential. And that is what you see in this slide. Whole CAD patient, patient with DM, patient without DM. So it is 0 to 4. So the moment urinary ACR is more than 4, we consider 30 as normal. There is increase in events. This is all-cause mortality, and you whole CAD, patient with DM, patient without DM. So you can see the urinary albumin creatinine ratio, even so-called defined within normal range, there is an incremental CV loss. CV event rates are more. Again, a low level of mortality, low level of albuminuria and mortality. You can see 5, 6, 7, 8. These are kind of things which you will never even understand and appreciate. But then you see as it goes up, the rate is linearly related to all-cause mortality and cardiovascular mortality. We are talking of atherosclerotic events. We are not talking of HFrEF. We are not talking of kidney outcomes. So how the vascular continuum interacts and crosstalk is very, very important. Cardiovascular mortality, all-cause mortality, 30 is normal. I showed you 30 is so-called normal. So the moment you see any traces, you find there is all-cause mortality and CV mortality increase, even so-called within normal range. So there is a continuum of risk like cholesterol, like blood pressure. So one has to understand the risk is very much linearly related. Again, showing the same concept, normoalbuminuria, is it normal? No, it is not normal. So that is very, very important concept that so-called, we call normoalbuminuric, they are not normal. There is increased risk of CV events. And the endothelial damage, tubular damage, comorbidities, inflammatory state, they all contribute to another aspect of CV phenotype, that is heart failure. And you see a brief discussion about albuminuria as a risk marker for heart failure. Albuminuria is important in progression of heart failure, and it predicts incident heart failure. So not only the number of people having heart failure will increase, but they will progress also. And you can see it is 1.8 times, 30 to 70%. Here in renal, 2.7 times, 1.7, and MESA, it is 2.7. Eric study 2.5. That means the chances of having a new onset heart failure. This is the point which I want to show, that largely clinicians and researchers, unfortunately, are focused on eGFR. They have neglected the urinary albumin creatinine ratio in previous trials and upcoming trial. Look, Deliver, Emperor, Solist, Galactic, not reported urinary ACR. Again, DAPA HF, Paragon HF, not reported. So largely the trials, unfortunately, out of two markers of kidney which are originating, they are focused on eGFR, not on albuminuria. That is a challenge, and I'm sure the new trial should be mandated by bodies who dictate research, control research in India or in America, that both the compartments should be looked into outcome trials. And look, another way to look at it. The incident heart failure with preserved ejection fraction. Serially measured urinary albumin excretion is strongly associated with incident heart failure. So as the urinary albumin creatinine ratio increases, the heart failure incidence will increase. So that is another very important thing. And there is a very recent paper, although on eGFR front, but it talks about kidney function decline may precede heart failure event up to 1 year. So if we serially plot, we see cross-sectionally, when the patient comes to you, we see cross-sectionally eGFR, but rarely we see how is the trend unless you write it on your prescription. So it is a very recent paper just published in August that serial decline, the decline may precede heart failure event up to 1 year. So you should be more cautious if your GFR is falling, although the patient is stable, but such patient will develop worsening of heart failure in times to come. This is HFpEF patient. If the GFR is less than 60, which is more than 50% of heart failure patient, is a stronger predictor than LVEF. So despite I being a cardiologist, it was very challenging for me to assimilate that if GFR is falling, it is a stronger predictor of event than LVEF. As we understand, LVEF is a local phenomena, while EGFR is a systemic phenomenon. This is the same thing. Longitudinal changes in kidney function help identify patients with heart failure with reduced ejection fraction at higher risk of hospitalization or death. Unfortunately, all these trials have not taken into account the urinary ACR. I wish they have included both the components, urinary ACR and EGFR, but I'm trying to emphasize that these two basic investigations, which are very cost effective, not only predict the onset of heart failure, not only predict the onset of vasculopathy, but they also can predict the upcoming worsening heart failure or vasculopathy. So it's very naive to understand that high prevalence, it is associated with high prevalence of traditional risk factor may reflect generalized endothelial dysfunction, increased vascular permeability, and abnormal coagulation system. It is a marker of inflammation and may indicate the severity of end organ damage. So it's a very, very sensitive, expressive test, which is least exploited. Just to give you an idea, if we combine urinary ACR and EGFR, if both macroalbuminuria and EGFR less than 60, look at the event rate. Look at the CV death. So one of the simplest predictor of high event rate is if you follow kidney, you don't follow heart. EF is not that important as these two together. So macroalbuminuria and EGFR, look at the CV death, look at the CV events. So this is very, very important and often neglected. And that's why KDIGO has combined two. They don't say, look only at this. They don't say, look at only this. They have combined A3 with kidney failure 4 times risk, very, very high. So you can make out that if two are bad, the patient is really very, very sick. And that is the essence that KDIGO has combined the two. The risk is not related to one compartment. You have to combine both so that you can adequately calculate the risk. Just to summarize, this is not heart failure alone. This is CAD risk, stroke risk, and heart failure risk. So ladies and gentlemen, do not underestimate the virtues of urinary ACR. Normal, micro, macro. The mortality is so well related and it's such a cheap test. One can easily do it in any lab. One can do, doctors can do in their own clinic. There is an instrument from Abbott. There are strips. You can do it. So as the albuminuria increases, the risk increases. Just to summarize, and the point is, even in this area, which is so-called normally defined, the risk is not zero. The risk is linearly increasing. Of course, it bumps like this. And often it is described, even if you have urinary ACR doubling within physiology, within normal range, that means a patient who had a urinary ACR of 10, after 2 years become 20, he has 4 times increased the risk of CV events, although he is still normal. So that is the importance of urinary ACR. And just to show you, it means increase permeability. All the risk factors act on the endothelial cell. And this is a photo provided by my nephrologist colleague. You can have real defects where the albumin leaks from the glomerulus. This is electron microscopy, which shows defects in the capillaries of the glomerulus. There are various mechanistic pathways: chronic kidney disease, heart failure, ASCVD, hypertension, metabolic syndrome. How the albuminuria comes in these, this is not a talk related to mechanistic pathways, but I can say that urinary ACR is very, very important as a marker for onset and progression. All the guideline talks of both the functions. All patients with type 2 diabetes mellitus, they should be then subjected to urinary ACR and GFR at least annually. So the guideline talks of urinary ACR in all diabetic patients, urinary ACR for CKD assessment. ACC-AHA talks of CV assessment in selected patients. ESC recommends in hypertension. So there is a big gap in guidelines that even the guidelines are not advocating in coronary artery disease patient where still it is a very strong prognostic marker. So that is a gap in the guidelines that up to hypertension they are advising, but in chronic coronary syndrome patient, they are not advising urinary ACR. I think this is an upcoming indication in times to come. Lack of awareness is one thing that's why practitioners are not using. Lack of awareness of guidelines, inadequate financial incentive and cost, institutional fragmented healthcare, patient low disease awareness, guidelines, inconsistent advice among the guidelines. So I still feel when coronary artery disease is concerned, ESCHA guidelines are very, very silent on urinary ACR. They do talk about eGFR. The therapeutic goal is to reduce albuminuria and decrease CV events. It's a new therapeutic target because now we have enormous number of drugs which can work. How to go about if you are one of them, I'm not talking CKD, if you are one of them, check whether it is more than 30 milligram. If yes, retest it. The reproducibility of urinary ACR is very, very important. If it is more than 30, then you go on this algorithm for treatment. So you have to prove the consistency of oxidative stress and inflammation, blood pressure variability, glucose variability that can affect the urinary ACR. So you have to test 3 months apart to see its reproducibility. There are pharmacological methods, risk factor control, and lifestyle modification. We'll go the other way around. First, lifestyle modification, that you have to reduce albuminuria by limiting salt, physical activity, diet, and weight loss. They all help in reducing albuminuria. Aggressive control of blood pressure. Then again, there is improvement of reduction in albuminuria. Sprint trial, blood pressure 120 by 80, 25% albuminuria reduction, target BP 120. So if your patient has got albuminuria, probably there is a case for tighter control. Glycemic control is important. Protective mechanism prevent glycation damage kidney structure, and it is beneficial in long-term vascular health. The drugs are renin-angiotensin inhibitor, RAS. They are first-line drug. We have very strong evidence. You look at the CV endpoint, albuminuria reduction is important in heart failure reduction risk and CV event risk. Comparison between ACE and ARB, 17 randomized controlled trial when they were subjected to meta-analysis, there was no significant difference. But largely, there are people who still feel that ARBs are better in albuminuria reduction. The robust class effect and significant reduction in albuminuria is seen with most ACE inhibitors and ARBs. Blunted risk of progression to macroalbuminuria by valsartan, candesartan, and perindopril from micro to macro. So we may differ, but largely meta-analysis have shown that there is not much of difference between the ACE and ARB. Then the next drug on board, which really made us aware, is urinary ACR, is SGLT2 inhibitor. They slow GFR decline and progression of the disease, but they also reduce urinary ACR. This is Emperor pooled. Again, you see that cardiovascular death or first heart failure hospitalization patients, whatever is the patient, the risk reduction is there. So these drugs are very, very important, not only in reducing the urinary ACR, but also it translates into cardiovascular death and reduction in first heart failure retardation. This is regarding albuminuria and dapagliflozin. Diabetics, non-diabetics who showed reduction 36%, non-diabetic 20%, kidney endpoint improvement is in 0.19, primary endpoint 0.10, and at 4 months the value improves in diabetic patient but remains more or less same in non-diabetic patients. So heart failure event reduction, kidney event reduction by urinary ACR, and high event rate reduction, 14.8 were prevented per 1,000 patients, and similarly high urinary ACR, 17.3 events were prevented for 1,000 patient years. So SGLT2 in different albuminuric classes, there are different advantage, and you see from low to high, the protection is more. It is not that in high you have less protection, but in this case, even if you have high ACR, you have more returns, more dividends, because these are higher risk patients than otherwise. Clinical evidence of different trials, then you see 17% reduction in normal albuminuria, 30% in micro, 36% in macro, in credence, 30% reduction in urinary ACR within 26, 31% fewer participants progressed to higher albuminuria. So SGLT2 inhibitor very strongly protect against progression, and definitely in some of 1/3 of the patient, they can regress albuminuria. Just to summarize that SGLT2 inhibitors, 16 fewer heart failure event, 17 reduced MACE, combination with different 35%, and number needed to treat is 3, number needed to need is 23 at 3 years. So impact on all-cause mortality is there. If you reduce 50% of albuminuria, there is a reduction in all-cause mortality. We are always better together. We are in an era of combination therapy, GLP-1 receptor agonist, non-steroidal MRA, and they also have a role to play in urinary ACR. Traditional MRAs effectively reduce albuminuria when added to standard therapy. Non-steroidal MRAs reduced hyperkalemia risk, and they also significantly reduce albuminuria. So this is a study talking about dapagliflozin and eplerenone. Again, you can see a combination of two, more than 30% reduction in urinary ACR. When two are together, they are better. Similarly, more than 50% reduction in urinary ACR. When two are together, they are better. As I showed you, if you reduce 50%, the mortality reduction is quite huge. Then Finerenone, this is Fidelio DKD and Figaro DKD. You can see now we are understanding more and more about the Finerenone, which is non-steroidal MRA. And you see when this is used, the Finerenone with ASCVD, Finerenone without ASCVD, but those patients who have ASCVD, they have better outcomes. Then there is risk reduction is better, whether it is CV death or heart failure, whether it is all-cause mortality and kidney outcomes. So Finerenone, higher the risk, more is the return. And in Fidelity, CV composite endpoint were driven 14% and 23% in CKD progression. Finerenone with empagliflozin in CKD and type 2, this is the latest confidence trial. This is Finerenone and EMPA, Finerenone and placebo, EMPA and placebo. This trial was presented by Dr. Rajiv Agarwal from Indianapolis, who is a very famous nephrologist of Indian origin. He comes from UP, from a town called Varanasi. So he's a great, very renowned nephrologist, and he presented this data similar to what I showed you about DAPA and apleneron. Here it is finerenone and empagliflozin. These were the patient profile. Urinary median ACR was like this. HbA1c was like this. 28% patient had ASCVD. And you see when two were together, finerenone, EMPA, and together. Percentage change in urinary ACR in patients with chronic kidney disease, you can see that at 180 days, 30% or more of urinary creation. The unfortunate part is nephrologists are stopping their trials here. They do it at urinary ACR level and stop it. They do it at kidney outcome levels and stop it. If you remember in 2008, FDA came with the mandate that all drugs after rosiglitazone fiasco, that they have to demonstrate the vascular protection of these drugs. Similarly, I think it's a high time we demonstrate all these drugs and trials done by nephrologists. All these drugs and trials done by nephrologists should not stop at kidneys. They should include vascular outcomes also, because it affects the vascular outcome, and we have to see that how it reflects systemically. So urinary ACR drop 29% with EMPA, 32% in finerenone, 52% with finerenone empagliflozin, and you know that it is such a good event that the just a minute. Amtastid. You find there is a 52% reduction, similar presentation what we learned with apleneron and dapagliflozin. This is finerenone and empagliflozin, and you can see that there is a huge reduction in urinary ACR. Unfortunately, they are not reflected on vascular compartment. The trial stops at kidney. That is one very big problem with majority of the nephrology trials. The flow trial, which is GLP-1, and you can see in flow trial, urinary ACR less than 300, it did not change, but if it is more than 300, then there is 25% reduction in urinary ACR. And similarly, you can see that the effects are manifested on low, moderate, and high, and very high risk kidney patient. That is how you can see. So GLP-1 receptor analog doesn't work in low proteinuric state, urinary ACR, if it is less than 300, although this is only study, this is subgroup analysis, but if it is more than 300, then definitely 25% reduction in urinary ACR. So if you look at the consistency of semaglutide, whatever is the baseline GFR, whatever is the urinary ACR, there is reduction in event. If the urinary ACR is more than 2000, event reduction is still more. Statins are also known to reduce urinary ACR, and this is a meta-analysis which showed that there is a reduction in urinary ACR. It favors statin. Just to summarize, these are three important molecules: GLP-1, SGLT2, finerenone. Let us understand this diagram. Kidney and HFpEF, all these drugs are very important. Definite benefit, green definite benefit, yellow definite benefit. MI, definite benefit, definite benefit. Finerenone is limited evidence. CV death, limited evidence, definite evidence, definite evidence. HFrEF, we don't have much data in Finerenone. In fact, Finerenone is still in cardiology not recommended. Finerenone is class 2 in the recent, class 2A in recent Japanese guidelines in HFpEF. There is no such a recommendation of changing aldosterone inhibitors like aldactone and eplerenone to Finerenone in HFrEF patient. SGLT2, strong evidence, definite evidence. We don't have much data of GLP-1 receptor analog in HFrEF patient. So this is stroke, doubtful, doubtful, strong. I think that is the simplest expression how these molecules are evidence-based in different indications. Kidney, HFpEF, all of them are very, very important, and all of them reduce urinary albumin-creatinine ratio. Just to give you an understanding, I'm last couple of minutes. If we look at the combination treatment, this is diabetic patient and albuminuria, you find the MACE reduction in maximum with SGLT2 GLP-1 receptor. This SGLT2 GLP-1 receptor non-steroidal. SGLT2 1 receptor. So if you look at the trials, the best outcome comes in patients who are on these three drugs. These is diabetic population, CKD progression, all-cause mortality. Roughly, you can make out it is around 33%. We have been brought up with MACE. Cardiologists were obsessed with primary endpoint, which is CV death, stroke, and non-fatal MI. Non-fatal stroke, non-fatal MI, and CV mortality. And we said we will test everything on these three compartments. Nephrologists were obsessed with creatinine doubling time, need of dialysis, need of transplant. So there was a China wall between the cardiologist and a nephrologist. Cardiologists were not talking as a vascular continuum, the effect of their drugs on nephrology, and nephrologists were not talking about the effect of their drugs on vascular compartment. So Dr. Deepak Bhatt came with an idea that in times to come, we have to change MACE to MARS, major adverse renal cardiac events, which is a better holistic indicator of the effects of these drugs on vascular compartment. I strongly feel and advise that somebody has to look all the EMPA-REG outcomes and all these trials where one has to include as a review of these trials the renal and the CV outcomes together. I'm sure the NNTs will come in single digit, and that will transfer enormous confidence to the clinician that they are doing exceptionally good job by holistically affecting the vascular tree. And that is the upcoming challenge. Two things which I understand is all the trials should be mandated for urinary ACR and EGFR, and all the trials should be mandated for MARS rather than MACE. So I'll end up by saying is a very strong risk marker. Beyond heart failure, it is a very strong marker of vasculopathy. It reflects oxidative stress. It reflects permeability, increased permeability. It reflects inflammation. It reflects the risk on the vascular compartment all over the body. Do not confine the risk to the kidney because of urinary ACR. It is highly prevalent. It's a modifiable target. When you modify target, the outcomes are improved. So ladies and gentlemen, this is a very, very simple test for clinicians to do in their clinics as a marker of vasculopathy. It often predates the worsening of heart failure and vascular event. So I'll conclude that albuminuria or urinary ACR is equivalent to silent ischemia of endothelium in general. It is not ischemia. I'm just correlating and using a corollary like silent marker of endotheliopathy, which reflects all over the body. Do not confine urinary ACR to kidney only. This is my last slide to show you that if you keep first slide I showed you, you have to be innovative. So if you keep using old bricks, you will never be able to build the new house. Or if you use old bricks, you will make the same house again and again. This is a very simple test. We have to think out of box to understand that urinary ACR is a very, very important test, cheap, effective, reproducible, and management of vascular dysfunction. Thank you very much.
This is one of the wonderful lectures, sir, today. I think for opening comment, I will take from Dr. Asutosh Chaturvedi on this, your talk.
Absolutely, sir. I compliment Dr. Rajiv Agrawal, sir, for such a wonderful lecture. It was very comprehensive. Your voice is really smooth, sir. Your vocal cords are really good. The talk was such a brilliant that it's a mesmerizing talk, because such talks, including the studies, are sometimes, a lot of times, boring for audience, but it was really good talk. And I completely agree with the emphasis on routine ACR testing. Unfortunately, as you also mentioned, that many of us check it only in diabetics, but evidence shows it's equally valuable in hypertensives and metabolic syndrome also.
In coronary artery disease also.
Yes, in coronary artery disease also.
You see, I'm sorry to interrupt you. If there is a patient of coronary artery disease and he shows urinary ACR, he becomes polyvascular disease.
Yes.
And that means it is altogether very high risk profile.
Thank you. Dr. Harshpreet, I think your initial comment. Yeah, Dr. Harshpreet from Ambikapur. Yeah, Dr. Harshpreet, are you listening?
Yes, sir. Good evening.
So your comment on this talk and your first opening comments.
First of all, Rajiv sir, very good evening, and thank you so much for such crisp and informative presentation, sir. Wonderful presentation with all the supportive evidence-based researches. Sir, just one question I want to ask you. Like we all said in the young hypertensives also and the young dyslipidemics also, if we should go for UACR. So the UACR, we should do a spot urine albumin creatinine ratio, or we should go for 24 hours urine collection report, which will be the much better, sir, for patients. And sir, is there any guideline that below the age of 30 years, those who are young hypertensive, should we go for the first screening urine albumin creatinine ratio also with the other parameters?
Urinary ACR is what you say, 24-hour is ideal, but it is not practical.
Yeah, exactly.
Who will bring 24-hour collected urine and then you send it for testing and all that? So this is ideal you are talking, but the substitute is the urinary ACR spot urine in the morning sample. This comes from Abbott company. It is a very small instrument, and the reports is available in no time. The strip cost around 350 rupees. And at least in any vascular disease like diabetes, hypertensive, suppose there is a 30-year-old guy, you have demonstrated albuminuria in his hypertension. You know he's a very high vascular risk.
Yes.
So instead of going to coronary artery calcium and all those things, this is such an important thing. And I was amazed to see with the very recent data, not old data, that worsening of urinary ACR and worsening of eGFR precedes the worsening of heart failure.
Heart failure, exactly.
So you can know this guy is going for heart failure next year.
Yeah.
So worsening of these two things is very, very important, very simple. And if you do it once in a year, I think this is a cost-effective test.
Thank
and
you,
the moment you make it, you see diabetes, urine albuminuria, coronary artery disease, he becomes polyvascular.
Polyvascular.
So
And
the,
many of the young patients we are seeing, sir, in the age of 25 and
you
31,
see,
they are doing it very well.
60% of our patients are less than 50 years of age.
Exactly.
So one of the problem and challenges is we do not give high intensity statin or lipid lowering therapies because we do not understand vasculopathy in a young hypertensive.
Young and hypertensive.
If your albumin creatinine ratio, urinary ACR is suppose 300, he is hypertensive control, I'll say this is an opportunity to use disease modifying agent for kidney and vascular tree. You have to bring in high intensity statin in these patients because they target organ damage.
Yeah. Thank you so much. Sir. Very important.
Yeah, so Dr. Akash, there are few questions we have received.
Yes.
Can you take the questions?
Sure.
You see that the chat box, Akash, you are unmuted.
Dr. Akash, you can see the chat box.
Yeah.
The first question is, why is urine albumin creatinine ratio considered a stronger predictor of CVD risk than serum creatinine or eGFR alone?
You see, it's more of a vasculopathy. It is endothelial. So it reflects general health. And I'm not saying it is more important than eGFR. Both are important. And they work exceptionally good if they are combined.
Second question is, at what threshold of ACR elevation should physicians start considering patients at very high cardiovascular risk?
If it is more than 30, yes, they are very high risk. And I have showed you enough data. If urinary ACR moves from 10 to 20, you are still within the range, but you have double the risk.
The third question is, how do microalbuminuria and macroalbuminuria differ in their prognostic implications for MI, stroke, and heart failure?
Proteinuria, the quantitatively proteinuria correlates with worse vasculopathy. Higher the proteinuria, worse is the vasculopathy. Like cholesterol, if you have 150 LDL or a 200 LDL, there is a continuum of risk. The cholesterol risk, LDL, the vascular risk does not decrease at 100. It doesn't become zero at 100. The risk is low. So there is a continuum of risk within the normal range, which becomes very high the moment you cross the normal range.
The fourth question is regarding the screening guidelines for urinary albumin creatinine ratio. When should we screen and what should be the frequency of screening?
I am not aware about Indian guidelines. Screening is very clear that it should be at least once in a year.
Do recent ADA, KIDCO, or ESC guidelines differ in their recommendations regarding albuminuria and CV risk stratification?
No, the most of the guidelines at the moment are not focused on atherosclerotic compartment of urinary ACR. They are more on heart failure. They are more focused on renal outcomes. That is the challenge. And that is why I say all the nephrology trials should reflect on cardiology. All the cardiology trials should reflect on nephrology. That's why the newer concept of MARS instead of MACE, that we have to have holistic vascular risk assessment. And if we are doing an intervention, holistic risk outcome.
What are the pathophysiological links between albuminuria and atherosclerosis, endothelial dysfunction, and heart failure?
Inflammation, oxidative stress, and increased permeability because of all the common risk factors. Endothelium is endothelium. So all the risk factors which affect your coronary endothelium will affect the same way the glomerular endothelium. So it's a marker of a vascular endothelium. They may change in duration, like somebody may start at glomerulars, somebody may start at coronary, but ultimately all of them will be involved. So vascular bed involvement may differ from the point of initiation of the disease, but ultimately all the vascular beds are affected.
Is there any evidence that albuminuria predicts CV risk independently of blood pressure, glycemia, and
Oh, yes,
LDL levels?
yes. It predicts independent of that.
The eighth question is, which drug classes, that is RAS blockers, SGLT2 inhibitors, GLP receptor agonists, MRAs, are most effective in reducing
I
ACR
showed
and
you.
CVD events?
Yeah, I showed you lifestyle modification, ACE, ARB, any one of them. SGLT2 inhibitors, MRAs, we have some data with Finrenon, and then finally GLP-1 is all of these drugs. Like you see, we should feel these are vascular drugs.
The question emphasizes if any particular drug class is most effective. Is it data about of all of these?
I'll say we no longer talk in which is most effective. The time is all together. Like in diabetes, like in hypertension, like in lipids, there is no concept of using one drug more than others. You have to display all the drugs as early as possible in sub-therapeutic, sub-target dosage. It is important because the pathways are different. Pathways are different. So you have to use different pathways to bring the maximum effect rather than up titrating the target dose of one class.
In clinical practice, should albumin regression be treated as a surrogate endpoint for CVD prevention?
Oh, definitely. That is the message, that it is a surrogate marker. It is a surrogate marker for high vascular risk.
How can routine ACR testing in primary care change long-term outcomes for high-risk patients in India?
Urinary ACR is a very simple clinical test, can be done in any clinic, any lab, and the risk, the moment you define the risk, the treatment aggression changes both in the minds of patient and clinician alike. Often we show our patient, look, last year your urinary ACR was 500, it has come down to now 300. They feel very happy. Doctor, our kidneys are doing better. You see, one of the biggest problems we face in clinical medicine in terms of compliance is we are not translating the benefits of the treatment over a period of time to patients numerically. We say, आप अच्छे हो रहे हैं, उसको कुछ नहीं पता चल. So similarly, we do it. There is a lot of work in the cardiology that you show carotid intima thickness, treat it and show regression. Patient will be compliant. So always it is better that we create a baseline document, show the treatment, like we show ejection fraction to our patient. Last year, our ejection fraction was 25. This year, because of sacubitril valsartan and all four pillars, it has come up to 35. He feels very good. He becomes compliant. The other situation, we say your 25 is 25 after 1 year, it has not deteriorated. So patient has to be given an objectivity in terms of his participation in understanding the treatment benefit.
So, what the major problem, this is a question from my side, major problem in preventive strategies is that we don't have the numbers to show the patient that these are the numbers which are improving. So I think insulin levels, hepatic enzymes, urine ACR,
Yes.
your fat distribution, all these can be used by all the primary care physicians to demonstrate that they are deriving benefit from preventive strategies. Otherwise वो बोलते हैं SGPT 40 है 45 है वो he doesn't वो कुछ नहीं है nothing will happen. That is what the patient thinks. So we have to have some numbers, and I think urine ACR is a very important number to demonstrate to the patient that they are benefiting from lifestyle interventions and the medications, preventive medications.
I fully agree, sir. I fully agree.
I
Yeah,
request
Dr.
Dr. Sangram Biradar to
Yes.
give his comments and if he has anything to.
Yeah, sir, is there any Indian data to suggest correlation between ACR, the coronary calcium, and the LDL levels?
This is a very good idea, but I am not aware. It should correlate well. Your let me say thought process is very appropriate. That we should have some data, and I'll Google it after the meeting. Urinary ACR and coronary calcium. There should be strong correlation. I agree with you, but offhand I cannot answer you.
Yeah, because this is one of the important marker in
Yes,
corporate sector
both.
is okay. Yeah, in
Yes.
corporate sector is okay, sir. But 80% of the rural physicians they rely only on albuminuria, albuminuria. So a very sensitive parameters, we should have a standardization and a validation of the parameters itself.
Yes.
Because whole management will depend upon the ACR, the
Yes.
readings.
That is
So
why
basic,
that is why I said that it has to be repeated after 3 months to see the reproducibility of quantitative and qualitative ACR. How much we are able to reproduce. If there is too much of variability, we'll go haywire.
Yeah. So are there any other Indian data, sir?
I'm not aware. I'm not aware.
Guideline. Yeah.
No, I'm not aware.
Because whole methodology of management is now reflecting on this, like LDL, ACR, HbA1c for diabetes, LDL for cardiology, ACR for kidney. That's why quite long back, 20 years before, Dr. M.K. Mani, he had a grassroots level. All patients are diabetic. He screened for albumin. That was a macroalbumin at that time, urine precipitation test. For all such patients, he started giving NLFL 2.5. So that prevented the patients going in for CKD and all.
That's, yeah. So I think Dr. Akash, Dr. Vijay Patni there. So I think he has left some to do. So I think I now will request to give the take-home message. The first I will start from the Asutosh Chaturvedi. So what is your take-home message for our physicians?
Sir, I think from today's CME, very important CME, the take-home message from audience should be that we must start targeting ACR reduction as an endpoint. Just like we are targeting HbA1c or LDL. So in kidney cardio patients, we must target it as an endpoint, and it should be a part of routine screening.
Yeah, that's fine. So Dr. Harpreet, your take-home message?
Sir, just from today's CME, I got one idea, sir. Just want to contribute it. Sir, right now I am doing 300 medical student screening for young metabolic syndrome. So, sir, when I am screening for metabolic syndrome, I am thinking of adding urine albumin creatinine ratio in all these students, sir. So this will be a much better, and after consecutive 3 months, sir, we can also check the reduction. But first, I want to know, sir, in the criteria of metabolic syndrome, like we check for obesity, central obesity, dyslipidemia, although there is in definition, the urine albumin creatinine ratio is not there. But after this CME, sir, 100% it's a take-home message for me also that I will screen all the 300 students for urine albumin creatinine ratio also. So that in the younger stage only, sir, if they are having, we can prevent them by giving statins for the future cardiovascular risk. So thank you so much, sir, for such a wonderful presentation. Once again, it will benefit lots of patients, and in every patient, we have to do urine albumin creatinine.
Yes.
It should be treated as an end organ therapy, and we should target it like HbA1c as said by Ashutosh sir.
Like I'll say, urinary ACR is a standard test for nephrologists. For clinicians, when they are dealing with kidney, my emphasis is when you are dealing with chronic coronary artery disease, diabetes with CAD, look for urinary ACR. That will change it to polyvascular. And polyvascular means in chronic state, you can even bring in COMPASS, where you have to give Roxaban 2.5 BD, because COMPASS means general risk. It is in this situation, it becomes very, very important whether your patient is monovascular or polyvascular.
So albuminuria should be treated as a vascular warning sign, not just a
Yes.
renal parameter.
Yes.
Yeah, so Tangram Bedar, sir, your take-home message?
Yeah, ACR is a good modality, easily available. We should compulsorily do for all patients of correlated diabetes, hypertension, or MASH, or whatever it is. And we had a very good discussion talk by Dr. Rajiv Agarwal as usual. We only think we should concentrate mainly on our Indian data, Indian patients, and any other things which we come across in our everyday day-to-day practice. Thank you.
So Akash, you can now conclude the session and propose a vote of thanks.
Definitely, before closing vote of thanks, I will request Dr. Harshpreet to share his study, because we will also be very much interested to join this study, which looks
100%.
fantastic.
I will mail you one study I have already completed, and it is published in JAPI also, sir. I will share you that study. And the next study, as it is ongoing, I will 100% share in this portal also, sir.
Yeah, Akash, I forgot, sir. Dr. Rajiv Agarwal, sir, your take-home message, I think that I forgot, sorry. Your take-home final message.
No, final message is urinary ACR is a simple surrogate marker for upcoming vascular disease. Deteriorating urinary ACR is a marker of deterioration of the disease. Reduction in urinary ACR means recovery of vascular tree. So it's very, very simple. And earlier you do it. I am impressed with Dr. Harpreet. that he is thinking of it in a very early lifespan. And instead of very many fancy tests, if we pick up such individuals who have urinary ACR positivity, then such individuals will be benefited very early in life. You see, you guys are more conversant. The Indian non-communicable disease program starts at the age of 30. It doesn't start there, and it is too late. So the problem is our understanding of vascular tree is improving every day, where 30 is a very late start, but it is the earliest start permitted by ICMR. So we need to work, leadership like you should work on ICMR to bring it to like 18 years, 20 years, college exit, college entry. You see, unfortunately, I gave a talk on lipid passport. And lipid passport I meant was measure LDL of every individual in this country when he goes to school, when he goes to high school or intermediate, and to graduation. These three lipid limits, LDL assessment, will track you so much of vascular disease early on, and you can work on these individuals rather than manifested disease at 30 and 35. So I agree with Dr. Harpreet earlier, you do it better, you are, but probably the cost constraints, public acceptance, that is a one big inertia where we need to work upon as a group. Sir, you are muted. Dr. Singh, you are muted.
Sir, Akash, now you can conclude.
I thank Dr. Rajiv Agrawal for accepting our invitation to talk and for such an excellent talk, which was so engaging and almost was unanimously welcomed as one of the most important talks, basically, because he highlighted a very, very new concept, which is beyond what we are thinking about urinary ACR issue. So, our sincere thanks to him for being here and for giving such an excellent talk. I also thank Dr. Sangaram Biradar, Dr. Ashutosh Chaturvedi, and Dr. Harshpreet for moderating the sessions, for keeping the discussion rich and alive, and for giving their own valuable inputs related to the topic, which so importantly basically highlighted or enhanced the value of our session. I thank Dr. N.K. Singh and Dr. Vijay Patni for conducting these CMEs with so much effort every month. And these CMEs are going a long way to enhance knowledge amongst all members of our CME India group. I thank all the doctors who have attended in large numbers this session, and we'll come to know exact numbers from the USC, but they are generally 1,000 plus doctors who have taken out their time and attended our sessions. I encourage them to attend the future sessions too. I thank the USV company for promoting the education and for giving us a digital platform for conducting these CMEs. I now request Dr. Ashni from USV to conclude the session.
Sir,
I
just
think,
1 minute. Sir, just I would like to take this stage as an opportunity for just 1 second, if NK Singh sir permits me.
sir, what
Please,
about,
please.
sir?
Sir, just I want to convey a message to all that, as we know, we have upcoming RSSD elections also, and one of
Oh,
the
that's
contestant
true,
was,
but Harpreet,
but this is not
I
allowed, I
think
guess. This is
it
violation
will be
of
not,
rules.
yeah,
Okay,
so
no
we
issues,
don't.
no issues. Yes,
Yeah,
sir.
thank you very much. Thank
Yeah.
you. Thank you for concern.
Your
Sir,
message
So I
is
think,
your message
yeah,
is well taken up, Harshpreet. Don't
sir,
worry.
sir,
yeah,
thank you,
yeah,
sir.
yeah. So,
Thank
so
you.
anyway, so I think Dr. Ursil has left. So thank you all, sir. It was a wonderful,
Thank you, sir.
I think, lecture we
Thank you.
today, and we become wiser. Thank you again. Thanks, and with I will end here. So good night.
Thank you.
Thank you, one and all.
Thank
Thank
you.
you.
Thank you, sir. Thank you.
Thank you. Good night.
Good night, sir.